Welcome back to the Equine Anatomy lectures. Today we will continue on this topic by talking about the anatomy of the hind limb. We did start on that by stating the different regions on the hind limb and then the different articulations after that. We then talked about the different muscles. We focused on the semimem and the semitens because they are utilized for intramuscular injection in horses. That's in addition to the splenius muscle in the neck. Also, we talked about the trochanteric bursa. Uh, After that, we talked about the innervation of the hind limb. We talked mainly about the innervation that's on the lateral side, which comes from the sciatic nerve that divides into two nerves, the tibial and the fibular. The tibial supplies the extensors of the hock, and the fibular supplies the flexors of the hock. Then we talked about the femoral coming from the medial side, and it supplies the quadriceps muscles, and it keeps the stifle extended. Now we did also talk about the operator nerve and how this nerve is going to be injured in some cases during parturition. Now after that we talked about the pelvic region and especially about the sacroiliac joint, which attaches the ilium of the pelvic bones to the sacrum, or to the vertebral column at the sacral region. And we mentioned that rupture of this sacroiliac joint or will cause a case that's called Hunter's bump, sacroiliac subluxation. Um, Today we will talk about the hip joint. This is the hip joint, and the hip joint is an articulation between the head of the femur, right here, and the acetabulum. The head of the femur and the acetabulum, acetabular cup, and this is the joint itself. Now, the articulation is strengthened by a number of structures. First, let's take a look at the acetabulum and how it is formed, and then after that we'll talk about the structures that strengthen this articulation. So this is the acetabulum of the horse, and this area here indicates that there is no bone in this region. So the acetabulum is basically incomplete bony cup, an incomplete bony cup. Okay, so knowing this fact now, there is a number of structures that makes the head of the femur attaches to this acetabulum pretty strongly, which also prevents the case that's called hip subluxation in equine, unlike small animals, which it's more frequent. In horses, hip subluxation is less frequent because of the following structures. First, the accessory ligament of the head of the femur. Number two is the ligament of the head of the femur. Number three is the transverse acetabular ligament. The transverse acetabular ligament. Okay, so how is each of these structures participate in the strengthening of the hip joint? First, you have the accessory ligament coming from the prepubic tendon of the abdominal muscles. If you remember the abdominal cavity, abdominal wall, the accessory ligament of the head of the femur comes from the prepubic tendon of the abdomen and inserts on the fovea of the head of the femur, right here. The second structure is the ligament of the head of the femur, which originates from the fovea of the head of the femur and inserts on the floor of the acetabulum, the floor of the acetabulum. The third ligament is the transverse ligament of the acetabulum, which basically completes or closes the acetabular cup. It closes the acetabular cup. So these structures, one that's coming from the abdominal muscles, one that's going from the head of the femur. Realize, please, the direction of the tendon. This tendon of the accessory ligament of the head of the femur is going toward the femur from the abdominal muscles. The ligament of the head of the femur is going from the head of the femur toward the acetabulum. So these are two different directions. One is coming this way, one is going that way. One is coming this way, one is going this way. One is coming toward the head of the femur, the other one is going away from the head of the femur. Now, these opposite powers locks the head of the femur into the acetabular cup, which is completed by the transverse ligament of the acetabulum. This is an extremely important biomechanical structures. So number one is the accessory ligament of the head of the femur, which is coming from the prepubic tendon of the abdominal muscles and inserts on the fovea of the head of the femur. This is number one. So its direction is from the abdominal muscle toward the head of the femur. The other one is the ligament of the head of the femur. It's originating from the head of the femur and inserting on the acetabular floor. The direction is opposite. The direction of the ligament of the head of the femur is opposite to the accessory ligament of the head of the femur. The orientation of these directions makes it hard for the head of the femur to leave the acetabular cup, which is completely closed by the transverse ligament of the acetabulum. This is basically the extent of our discussion on the hip joint. So three structures are extremely important to stabilize the joint and to prevent it from subluxation. Now we go to the stifle joint. The stifle joint consists of two joints, femorotibial and femoropatellar. Femorotibial and femoropatellar joint. Two joints in the stifle joint. This is the femur. This is the medial trochlea of the femur. This is the lateral trochlea of the femur. This is the tibia. So, and this is the patella right here. So the first joint is the femorotibial, and the second joint is the femoropatellary joint. Now, in the femorotibial joint, there are two compartments, medial and lateral compartment. Medial and lateral compartment. In the femoropatellary joint, there's only one compartment. However, the femoropatellary joint communicate 75 or 80% of the times with the medial compartment of the femorotibial joint. Now, let me draw your attention to the fact that the lateral and the medial compartments of the femorotibial joint, these two compartments do not communicate. Do not communicate. Meaning that if I have a problem with one of them, I have to inject that specific compartment. I cannot inject the other one and hope that it will, and the medication is going to go to the other compartment because they communicate. They do not communicate. So the medial and the lateral compartments of the femorotibial joint do not communicate. Now, the medial compartment of the femorotibial joint communicate 75 to 85% with the femoropatellary joint. With the femoropatellary joint, 70 to 85% they communicate. Meaning that when I have a problem with the femoropatellary joint, I can inject the medial compartment of the femorotibial joint and the medication is going to go to the femoropatellary joint. The communication with the lateral, between the femoropatellary joint and the lateral compartment of the femorotibial joint, only communicate at 20-25%. So it's not safe to inject one of the compartments and hope that the medication is going to go to the other. They have to be injected separately. They have to be injected separately. But if I have a problem with the medial, I can inject either the medial or I can inject the femoropatellary joint, and the medication is going to go to both. If I have a problem with the femoropatellary, I can inject the medial compartment and the medication is going to go to the femoropatellary joint. This is a very important structural characteristic of the stifle joint. So again, the stifle joint consists of two joints, femorotibial and femoropatellary. Femorotibial, this is the joint right here, and it consists of two compartments, lateral and medial, and a femoropatellary. This is the joint right here, and this is the joint space right here. Now, the patella is guarded by a number of structures that keeps it, or that keep it, sliding and gliding on the trochlea of the femur and on the tibia. So the joint can be unlocked. The joint can be unlocked, meaning that the stifle can be flexed, because with this position here, the stifle is going to be always extended. So, what are the structures that guard the patella? First, we have the medial patellary ligament. We have the intermediate patellary ligament. We have the lateral patellary ligament. And we have the patellary fibrocartilage. So, 4 structures along with the patella. The patellary fibrocartilage is 1, medial patellary ligament, intermediate patellary ligament, and lateral patellary ligament. There are also cruciate ligaments and collateral ligaments. So we have crucial ligaments and we have collateral ligaments, medial and lateral, and this is the meniscus or the menisci to minimize the pressure on the heavy joint. Now, how is the stifle joint kept in motion? We have 3 different pictures here that will explain what we will call the patellary locking mechanism. The patellary locking mechanism, which is the first component of the passive stay apparatus of the hind limb. The passive stay apparatus of the hind limb. Remember the passive stay apparatus of the forelimb? This is the first component of the passive stay apparatus of the hind limb, and it consists of the following: the patellary locking mechanism and the structures that participate in this locking mechanism are patellary fibrocartilage, medial patellary ligament, lateral patellary ligament, and patella. Again, the first component of the passive stay apparatus in the hind limb is called the patellary locking mechanism. The patellary locking mechanism consists of the following structures: 1, patella; 2, patellary fibrocartilage; 3, medial patellary ligament; 4, lateral patellary ligament. Please realize that the intermediate patellary ligament is not including in the patellary locking mechanism. The patellary locking mechanism, it's not included. The intermediate patellary ligament is not included in this locking mechanism. Only the medial and the lateral patellary ligaments, the patellary fibrocartilage, and the patella. Now, these structures, the lateral and the medial and the patellary fibrocartilage, guard the patella to slide and glide, if you will, on the femur and on the tibia. Once this happens, once the patella is or pops up the medial trochlea, again guarded by the medial and the lateral patellary ligaments and the patellary fibrocartilage, it slides down, giving the stifle joint the ability to flex. If the patella continues to be riding on the medial trochlea of the femur, this is the femur, this is the tibia and the fibula. If the patella kept sitting on the medial trochlea of the femur, the stifle will always be extended. However, with the help of the lateral, the medial patellary ligaments, and the patellary fibrocartilage, the patella is moved from this position to slide and glide on the femur and on the tibia. This movement will allow the stifle to flex. This movement will allow the stifle to flex. This is the patellary locking mechanism. That's why it's called locking, because it locks the stifle in the extended position. But it moves up and down, the patella moves up and down from the medial trochlea of the femur. It moves up and down, jumps up and down, guarded by the medial and lateral patellary ligaments and the patellary fibrocartilage. It's guarded so that the stifle can be flexed instead of extended all the time. So the stifle can be flexed. Now, sometimes in some pathological cases, some conformational problems in certain horses, and the patella stays on the medial trochlea of the femur. When it stays, the horse looks like this. The stifle is completely extended, and the limb is fully extended. Because if the stifle is extended, then the hock is definitely extended. And I'll explain that after this mechanism. So the stifle becomes extended if the patella does not move. This case is called an upward fixation of the patella. An upward fixation of the patella. And in order for you to fix this case, you cut the medial patellary ligament in a standing horse. Once you cut the medial patellary ligament, the patella is basically released from its locking position, and the stifle goes back to its normal. Of course, it takes some time to heal, but the limb goes back to normal. So this is the upward fixation of the patella. You fix it by cutting the medial patellary ligament. We call that medial patellary ligament desmotomy. Desmotomy. Cutting the ligament. Medial patellary ligament to unlock the position of the patella. Other cases, of course, you can utilize also the medial, intermediate, and lateral patellary ligaments, as well as the collateral ligaments, as landmarks to do arthroscopic surgery in the stifle. This is a picture showing the stifle joint and removal of some of the synovial lining. Here, this is the lesion, can appear clearly after cleaning the joint. This is at the end of the surgery. Basically, the key here is to utilize the medial, intermediate, and lateral patellary ligaments, as well as the collateral and the cruciate ligaments on the caudal aspect. So the medial, intermediate, and lateral are from the cranial aspect of the stifle. The cruciates and the collaterals are from the medial and lateral aspect, as well as the caudal aspect. They're all used as landmarks to get into the stifle joint for arthroscopy. This is basically how a surgeon is measuring where to cut. to get into the medial and the lateral compartments. Again, utilizing the medial and the lateral and the intermediate patellary ligaments. Femorotibial arthroscopy, medial and lateral compartments. Again, here you will see this is the patella, this is the patellary fibrocartilage here, medial patellary ligament, intermediate patellary ligament, lateral patellary ligament. These are the collateral ligaments, lateral and medial collateral ligaments. So you have the camera getting between the lateral and the intermediate patellary ligaments, and the instrument or the forceps. We call that a Ferris-Smith forceps. We put it between the collateral and the lateral patellary ligaments. So this will get to the lateral compartment of the femorotibial joint, whereas here you get to the medial compartment of the femorotibial joint by putting the camera between the lateral and the intermediate patellary ligaments, and the tool or the Ferris-Smith forceps between the medial and the intermediate patellary ligaments, as seen in this picture. And here, this approach is called the triangular approach because the surgeon is going to be standing here. So the body of the surgeon is here, the tool is here, one hand is holding the tool, the other hand is holding the camera. That's a triangle right here. Makes it between the surgeon's body, the tool, and the camera. It's a triangular approach. You will learn that in medicine and surgery later on. Okay, so this is the stifle joint. Two joints, femorotibial and femoropatellar. The femorotibial is the larger one. It has two compartments, medial and lateral. The femoropatellar has only one compartment. The medial compartment of the femorotibial communicate with the femoropatellar about 75% or more. However, the communication between the lateral compartment of the femorotibial and the femoropatellar joint is only 20-25%. And this needs to be taken into consideration with regards to joint injections, joint anesthesia, and things like that. Also, we've talked about the patellary locking mechanism, which is the first component of the passive stay apparatus of the hind limb, which keeps the stifle extended and flexed under the guard of the patella, patellary fibrocartilage, medial patellary ligament, and lateral patellary ligament. The intermediate patellary ligament does not have a role in the patellary locking mechanism. Now, sometimes when the patella is locked, we call that upward fixation of the patella. To fix it, we need to cut the medial patellary ligament. When we cut that in a standing horse, the stifle immediately flexes and the horse goes back to normal. So the patellary locking mechanism prevents the stifle from flexing. It keeps it extended. Okay, so now we get to some of the muscles on the leg, and we'll see how those muscles are organized and how can we utilize them clinically. These are the muscles of the leg in the horse, and I want to focus on a number of muscles, but we'll talk about them in the next time. For now, we will just mention that the muscles on the dorsal and the lateral aspect of the tibia are the long digital extensor, which is the only tendon here that reaches P3, just like the common digital extensor in the forelimb. We also have the lateral digital extensor, and we have the lateral digital flexor. Also realize, please, that the tendon of the lateral digital extensor joins the tendon of the long digital extensor right here at this point, at the mid-metatarsal area, dorsal, on the dorsal aspects of the mid-metatarsal. On On the ventral aspect, we have the gastrocnemius muscle. We have the superficial and the deep digital flexor tendons here. And now when we take, we'll talk about this picture after we talk about the importance of these two muscles, the long digital extensor and the lateral digital extensor, in the next video.